like respiratory acidosis and alkalosis. So we're just going to start reviewing things about gas exchange. So we have our alveolus right here, and we have blood coming in, and blood coming out, right? So we always have a venous pressure that we have of CO2 that's coming into the blood, right? And we have a arterial pressure of the CO2 that's coming out, right? And then we have alveolar pressure too, pressure over alveolus, and that's denoted by big A. So small a, arterial, big A, alveolar. So generally, when we have blood coming in, we have more CO2 coming back to the lungs, right? We've used up our oxygen, we've made our CO2, and now more CO2 is coming back in to do gas exchange. And usually this number is around 46-ish before gas exchange. Then our CO2 comes out, our O2 comes in, and then our PaCO2 after that becomes about 40. And the reason why this happens, that it's 46, 40, those numbers, is due to a couple of reasons. One is that because we don't have a perfect system in our lungs, right? There's some dead space that we have in our upper lungs that don't do gas exchange, and then we have, you might have other underlying pathological diseases, but in a perfect system, we should theoretically, any CO2 that we exchange should come out and be the exact same, right? So whatever the PaCO2 in the lungs should come out to be the expired CO2. So, but because we have dead space, we have some other things that might be going on in our lungs, that's not always the case. We have dead space that we have that's mixed with CO2, and it's mixed with alveolar air. So that actually decreases the ability of gas exchange. So usually in equilibrium, you would think your PaCO2 is equal to your arterial PaCO2, like it should be the same, like whatever comes in should be whatever's in the blood, but that doesn't happen because of this dead space here. So we usually have something called an AA gradient, where there's some difference in pressures that occurs just because there's other pressures pushing on the lungs that contributes to your alveolar CO2. So your AA gradient is about 10 to 15 because your PaCO2 is actually between 20 to 30, right? So you usually have 40 here, you have about 20 to 30 here. So there's a difference between the two CO2 pressures. And in some pathologies, this becomes important because sometimes gas exchange is impaired, so you have increased retention of CO2 in the blood, or sometimes you're having more produced overall, so it just that much CO2 can't get out from your blood. So this becomes an important concept later, so it's important to understand that AA gradients exist and what can contribute to them. So if we think about something that's a complete dead space, so in a complete dead space, we would have our alveolar pressure equal to 0, right? So this would be 0. And because this is 0, right, you would keep the CO2 in your blood, right? So you'll have more CO2 all across here. So if our alveolar CO2 is equal to 0, that means we're not expiring any CO2, right? So that our PeCO2, expired CO2, is also equal to 0, which would lead to CO2 increase in the blood. And that's one way that actually respiratory acidosis can happen, right? If you have increased dead space, you'll have more retention of CO2 in the blood. And that's one reason you can have respiratory acidosis. So obviously, it's never going to be 0, right? But if you have more dead space in your lungs for some reason, you have an increase of CO2 in your blood, so respiratory acidosis. But say for some reason you have less dead space, you have like really efficient lungs for some reason, you will have decreased CO2 in your blood, right? Because gas exchange is occurring much more efficiently, right? If you have decreased dead space, because you don't have this pressure pushing down on the alveolus and on the blood vessels. So you would actually get a respiratory alkalosis if this occurred. Does that make sense so far? Yeah, okay, cool. Moving on to O2 saturations. So if we think about a normal alveoli, right, usually about oxygen saturation in venous blood is about 70%. And coming out after it undergoes gas exchange, usually it's at 100%. Right, so that's generally the normal case. We get complete saturation of oxygen, but what happens if we have some sort of obstruction, right? What happens if we have an obstruction? So there's blockage in the vein, right? So you have 70% oxygen here, right? Just in one alveolus, but we have, so what would happen to the blood coming out? So generally, if there's an obstruction in one alveolus and not the other alveolus, you're gonna still have 100% oxygen that's gonna come out overall if you put the two systems together. Even though this is like, it's never gonna be fully obstructed, but for O2 saturation, it's, if one alveolus is working and can completely exchange blood, you will still have 100% O2 saturation. So this is, so if there's an obstruction here, this would be called dead space, right? Because you're ventilating your lungs, but you can't actually perfuse them. So in dead space, you usually have 100% oxygen saturation. And since you have 100% oxygen saturation, that means there's no hypoxia, right? Because you're still ventilating and able to exchange gas in one alveoli. So dead space itself doesn't actually lead to hypoxemia. So I think it's important to understand that even though you might have an obstruction in your blood flow, it doesn't actually impact O2 saturations. But if we think about O2 saturation in terms of shunting, so in terms of shunting, that means one alveolus, there's something wrong, right? It's not the blood, it's the air. So this is blocked off. So all the air gets shunted into the other alveolus, right? And you still have your 70% O2 saturation in your venous blood and your 100% saturation in your arterial. Yes, thank you. Words today have been hard for me. In your arterial blood, right? But because your blood flow is still working in this particular alveolus. So you have 70% of O2 coming in here, but because gas exchange can't occur, because there's no air that's coming into here, you still have 70% O2 coming out of this pulmonary vasculature for arterial, which leads to decreased O2 saturation, right? So in the cases of shunting, you're gonna have decreased O2 saturation, and that leads to hypoxemia. Right, so dead space, even though you might have a blockage in the blood, that doesn't actually impair gas exchange, right? But if you block the alveolus, it does impair gas exchange, so your O2 saturation is decreased. Does that make sense? Yeah, is there a question? Okay, no. Cool. Yes, okay. I skipped something. So just thinking about the alveolar ventilation equation. So if we want to figure out what the alveolar CO2 is, It's dependent on how much CO2 is being produced, which is your VCO2, times some constant over your normal ventilation minus your dead space, right? And so the three major causes that could really cause increased CO2 in your blood is if you have increased CO2 production, you have decreased VT, so you have hypoventilation, or you have increased dead space, right? And that makes sense. Like you have increased CO2 production, you have more CO2, decreased hypoventilation, you're retaining your CO2, dead space, it increases your CO2. So if you think about it in terms of the equation and you manipulate the variables, it would lead to increased alveolar CO2. And then going into lung ventilation, just gonna ask questions here, but I'm just gonna talk through it because no one's usually in prison. So if we think about where airflow is going in the lungs, we know that the highest ventilation is going to be in zone 3, right? And the reason why is because if you're sitting upright, your gravity is going to push all your air down to the bottom of your lungs, right? So your bottom lungs is going to have the highest ventilation. And then going upwards, you're going to have the lowest ventilation in zone 1. In terms of highest blood flow, for a similar reason, zone 3 has the highest blood flow, right? Gravity pushes the blood down into the base of your lungs, so you're going to have increased blood flow in the bottom of your lungs, whereas zone 1 is going to have the lowest blood flow. So if our ventilation is V and our blood flow is Q, right, we're going to have a VQ ratio, our ventilation perfusion ratio. We're going to have increased ventilation down in zone 3, but we also have very increased blood flow in the lungs. That's the highest amount of blood flow. So your VQ ratio is going to be the lowest at the bottom of your lungs, right? And in a general person, this is equal to about 0.6, right? So you're wasting blood flow in the bottom of your lungs just because it's very well perfused, but there's not enough ventilation to actually do gas exchange to the fullest extent. Zone 2, it has mid blood flow and mid ventilation, so that's like kind of in the middle where probably your gas exchange is probably like at an equal level, so it's around like the most efficient it can be for the lung. And if we think about the zone 1, your highest, you're going to actually have a high VQ ratio just because even though your ventilation is low, you have very few blood vessels at the top of your lungs, right? So that's going to actually lead to your highest VQ ratio, which is about 3 in normal adults. So for that, you have wasted ventilation. So you have a lot of air that can come into the lungs at the top of the lungs, but you don't have enough blood flow, so you can't do gas exchange that well in the top of your lungs. And generally overall for the lungs, the VQ ratio is about 0.8. And so if it changes the VQ ratio, and it can lead to specific pathologies, and that can mess up how much CO2 is retained and how much other metabolites, oxygen saturation is also as well. So if we go and think about the different pressures in the lung, so if we have a capillary here, we have venous blood over here, we have arterial blood over here. So there's pressures on the capillary from the arterial versus venous blood that causes blood to flow from venous to arterial. But we also have pressure also from our alveolus that compresses down on the capillaries, which can cause blood flow to be optimal or non-optimal, right? So if we think about zone 3, we're gonna have our highest arterial pressure, right? This is the highest blood flow at the bottom of the lungs, so it's gonna be your highest pressure. Same thing for venous blood. We have our highest blood flow here, so venous blood is gonna be generally higher of a pressure, but because usually arterial pressure is greater than venous pressure, that's why it's lower. And so the alveolar pressure at the base of the lungs doesn't really affect it as much. But if we move higher, in zone 2, our arterial blood is still pretty high. It's still in the mid-level. There's some blood flow going, but our alveolar pressure is greater than arterial pressure. Do we know why blood flow can still happen in this part of the lungs, even since alveolar blood pressure is greater than venous blood pressure? Because if you think about it, alveolar pressure, if it presses down on the venous side pressure, it's gonna collapse, right? Yeah, right, good job. It's because when your right ventricle contracts. So if we think about our cycle, the greatest pressure is due to right ventricle contraction. So at the peak of right ventricle contraction, your arterial blood pressure can actually open up your venous pressure side of the capillary, so it can allow blood flow to occur. So it can create this thing called like pulsatile flow, where depending on when your right ventricle contracts is what determines when the capillary flows the blood and allows gas exchange to occur. So it's something to think about, like when you're looking at these why PA is greater than PBK or PV, just thinking about like physiologically why is that happening, and it makes sense why these things are, instead of just being like, oh, memorize each thing. Yeah, and then zone 1, we have our alveolar pressure, since we're closest to the top of the base of the top of where the lungs expire. That's going to be our greatest pressure, and that is greater than or equal to our arterial pressure, which is greater than our venous pressure. So it has to be equal to in this case, because if we had if it was just greater, it would just compress, these would just compress on the capillaries, right? And no blood flow would occur. And there's very minimal blood vessels, so that makes sense sometimes while it's greater. But it has to be equal for at least some capillaries to have blood flow to occur. Does that make sense? Yeah, okay, cool. So let's write that. At least equal. And that's all I had for rest physiology. Now we're going to get into a little bit more of acidosis and alkalosis. So we're going to first start with respiratory acidosis. So respiratory acidosis, like by definition, you have a pH that's usually less than 7.37, right? And usually respiratory acidosis, for some reason you have an increased PCO2, right? Normally PCO2 is supposed to be between 35 to 45. And generally what happens for compensation for respiratory acidosis is that there's some reason there's going to be an increase of HCO3. And we'll get back to this compensation a little bit later. But if we think about some causes for respiratory acidosis, we hinted at some physiological principles earlier, but you know what would cause an increased retention of CO2? Think about physiology. What was the question? No, just like why would physiologically, what would retain CO2? Just like breathing mechanism. Oh, well, yeah, objective. I was just thinking like more like hypoventilation, right? If people hypoventilate, you have more, you have retained CO2, right? You have a decreased respiratory rate, so you have an increased PCO2 in your blood, right? And there's a lot of reasons why hypoventilation occurs. One could be due to decrease in CNS drive. So if you have certain drugs that you'll learn next year, like opiates or barbiturates, or just CNS disease in general, can cause a decrease in respiratory drive. Muscle disease can also cause decreased hypoventilation. And some examples, Guillain-Barré disease, which is something you will learn next semester. They love their Guillain-Barré disease. Polio, MS are just some examples of muscle disease. And the reason why is because your muscles are weak, it cannot expand the lungs easily. So you can't actually have that gas exchange occurring. So you have retained CO2 because of it. And then, yeah, Nathan, another reason for hypoventilation is obstruction. So like if you're aspirating on something, or if you have sleep apnea, that would cause you to just retain CO2. And then finally, if you have just impaired gas exchange. So all your fun lung diseases that you've learned about, like pneumonia, pulmonary edema can also cause it, COPD and ARDS, your acute respiratory distress syndrome can all cause impaired gas exchange in various different ways. I'm not going to go through them today because you probably had enough of that. And then the other way you can get respiratory acidosis is if you have overproduction of CO2 for some reason. So if you had sepsis is a good example. If you just have overproduction of CO2 due to whatever bacterial infection that is occurring in your body, you get respiratory acidosis as well. Liver failure can also cause overproduction of CO2 in various different ways that I won't go into today because you are not learning about the liver until next semester. Thyroid storm can also cause it, an overproduction of CO2. Again, you'll learn about that. We learned about it this semester. And malignant hyperthermia. So overproduction of CO2 is kind of a rare cause of why respiratory acidosis can occur, but it's in different ways. So if you think about it, like you're retaining CO2 or you're producing more CO2, that's going to be the reason of respiratory acidosis. And compensation for it, as I mentioned earlier, there's a couple different ways you can compensate. So if it's not due to, if it's an acute compensation, the blood can actually buffer for a little bit, not for too long if it's like a long-standing problem, but it can, if there's an acute cause for the respiratory acidosis, your blood can buffer it. So you have your hemoglobin that can buffer acid, protein in the blood, and phosphate that can all buffer the increased CO2 that you're producing. So that's an acute thing, but ultimately if you have a chronic disease, this is not going to do much for long. So chronic compensation, you're going to have a couple different ways. You're going to have increased HCO3 reabsorption by the kidneys, can be one reason to have compensation. You can have increased H+ filtration, or increased NH3 production to buffer the H+, or you can just have increased HCO3 regeneration. And the places where it happens, I'm not going to go into detail today, but Shy did, if you were at Shy's physiology lecture, she would have gone through where things were reabsorbed and filtered. So just thinking about the kidney in general, it takes a couple days for the kidney to compensate. So depending on how long and questions when you're looking at it, it's only been a couple of hours since the respiratory acidosis started, you're not going to see compensation. But if it's been like a couple of days, then you're going to probably see compensation in the bloods. And that's respiratory acidosis. Another page. Okay. And then finally, respiratory alkalosis. So for this one, by definition, you should have a pH over 7.42. And usually it's just due to a decreased PCO2 in the blood. And usually your resp rate is usually under 25, because usually you're hyperventilating in this case to try and get as much CO2 out of your lungs for some reason. And general compensation is just a decrease in HCO3 in the kidneys. So if we think about, there's like 3 major causes of respiratory alkalosis. One is hyperventilation, like I mentioned, and that makes sense, right? You're trying to get rid of as much CO2 as possible for some reason. And there's a lot of things that can cause hyperventilation.
Like being on mechanical vent.
Yeah, being on a mechanical vent is one reason to do it. But if you just think about physiologically for some things, if you're having like a panic attack or something, you're hyperventilating as well, and it can cause you to go through a respiratory alkalosis if it's that severe. Another reason is high altitude. And the reason why is because you have a low PO2 when you're at higher altitudes. It leads to hypoxia, which the hypoxia causes you to hyperventilate because you need more oxygen because you don't have enough oxygen that you're breathing in, which causes a decrease in PCO2. So that's why if people who are climbing mountains, something that they take is acetozolamide, just to break down the bicarb from the kidneys and excrete it, so you don't have this problem when you're climbing mountains. Something else that's like something specific that they like asking because it's like it tests your knowledge about 2 different types of disorders is aspirin overdose. So aspirin overdose, there's actually 2 different kinds of physiological problems it can cause depending on when it presents, or it can be a mix. It's a very good example of a mixed disorder too. So a lot of UWorld questions or step questions might ask like something like this if they want to really test your knowledge about it. So if it's an immediate overdose, what you're going to see is that the salicylates, which is a byproduct of aspirin, it stimulates the medulla. And because of the stimulation of the medulla, it's going to hyperventilate. So you have the hyperventilation initially, but then later on, chronically, you actually will see increased anion gap metabolic acidosis, which Shy will go over in her part of acid-base physiology. So I'm not going to go too much into details about what an anion gap is, but the reason why it causes it is that salicylates, the same metabolite, can also inhibit lipolysis, and it uncouples the oxidative phase as well, and it inhibits the citric acid cycle. So it does a lot of things, which can increase your acid production. So you accumulate lactate, pyruvate, and keto acids in your blood, which causes the increased anion gap metabolic acidosis. So depending on when it presents, you can have both at the same time. So you can have like a mixed disorder of it where the bloods might not always be the classic, oh, it's classically respiratory alkalosis or it's classically increased anion gap metabolic acidosis. So there's some ways to figure out whether if it's both or one or anything. Something that Shy will go over later is Winter's formula, which is the classic thing you use to figure out whether a mixed disorder is happening or not. But I'm not going to go into it now. Shy will go over what Winter's formula is, and it's essentially a formula that predicts what the CO2 should be in a metabolic acidosis. So, but in the case of aspirin overdose, the CO2 is lower than expected for compensation. So basically you have like a low CO, if you were thinking about compensation for a metabolic acidosis, you would have respiratory compensation that would decrease, I'm mixing myself up, that would decrease your CO2, but it's even lower than expected. So that indicates something else is going on with your body. So yeah, that's like an example. If you know this pretty well, it does come up in like STEP questions. For UQ, they're not gonna really ask you this. This would be like, why would UQ ask this? And some other causes of respiratory alkalosis, head injuries can cause it, stroke, and then some other pulmonary causes, something that you should probably know, like asthma with the hyperventilation. If you have an asthma attack, is something really important to know. And then pneumonia and a pulmonary embolism can also cause it. And Shai's going to go over this kind of diagram more in detail, but it's like a pretty step-by-step pathway to kind of identify, okay, I have a step-by-step system in order to figure out what kind of disorder is it. Is it a acidosis, alkalosis? Which system is it affecting and what the compensation is? But I'll leave Shai to explain that. Cool. Yeah, I'm done. Any questions before I turn over to Shai?
Now we're going to zoom through this because questions are going to be the most important part. Let me hop on Zoom.
Yeah, stop sharing.
Where is my Zoom?
That was me. I was like, where is my Zoom?
I love that it like counts down.
It's like
I
here,
think it's like this
3, 2,
thing.
1.
Okay, where are we starting? We are starting with the metabolic side. So Abby did all the respiratory side of acidosis and alkalosis. We're just going to quickly go over what metabolic disorders we're going to be looking at that causes acidosis or alkalosis, and then from there, are you good?
Yeah, I'm just gonna, when we do questions, I'm gonna,
Okay.
fine. Gotcha, you're good.
And then from there, we'll go into like how we're gonna approach questions. So let's start with alkalosis first. So metabolic alkalosis. Alkalosis means that there is an increase in your pH. Metabolic means that you are looking at a increase in your bicarb. What happens in compensation of this is that you will see an increase in your CO2 levels. So how did I just get all of that? Let's go back to that super fun Henderson-Hasselbalch.
Yeah, it's Hasselbalch, not Hasselbalch.
Henderson-Hasselbalch equation. So that equation in general is any pH by the pKa plus, do I actually know this? Okay, yeah. Plus the log of your base over your acid will give you the pH. So things that we know is that we are looking at your main acid base is going to be your bicarb is going to be your main base, and your main acid is going to be CO2. Why do we know that? We have that lovely carbonic anhydrase reaction that goes on. So if we take this Henderson-Hasselbeck formula and look at it for bicarb, we know some things. We know that the pH is going to equal the pKa of carbonic acid, which is 6.1 plus the log of your bicarb concentration by your acid concentration, which is your CO2, and you have to account for solubility, which is 0.03. So this is this magic formula that you just kind of just have to know. So again, this is your pKa of carbonic acid. And this is your solubility constant. Okay, so the mechanism of any alkalosis is you're either going to have a loss of protons, or you're going to have an increased production or ingestion of bicarb. That's your main mechanism here. So I'm going to split it up into two different types of metabolic alkalosis things. You're going to have a chloride responsive one. So Boards doesn't really do it this way. Ambos does it this way, which I think is kind of interesting. So chloride responsive means that there's a normal urinary chloride response. So that means you're going to see less than 25 millimoles per liter of chloride ions in your urine. So the main things that cause that are going to be vomiting, nasogastric suction, any sort of hypovolemia. So hypovolemia, Boards will call this contraction alkalosis. And the last thing would be loop or thiazide diuretics. So let me see which ones I want to focus I guess. Okay, so if we're looking at like any sort of GI acid loss, that's going to be like your vomiting or your gastric suction. The idea is that in your stomach, you're going to have parietal cells. It's like very basic GI. Your parietal cells make your hydrochloric acid. So let's say you're vomiting, or let's say you have a gastric suction of some sort, you are losing your stomach contents. So that means you are losing chloride, you are losing potassium, and you are losing hydrogen. All those things will result in alkalosis. And then let's talk about contraction alkalosis. Contraction alkalosis, or any sort of hypovolemia, the idea is that you are losing your total circulating volume, your effective circulating volume. What happens with that? So let's think of like vomiting causes this, diuretics cause this, so balloon thiazide diuretics, heart failure, cirrhosis, all those. Both of these are also treated by diuretics, so they kind of go back to that. So what's happening here is that you are increasing your RAS, you are increasing your sympathetic nervous system. Essentially what's going on in your kidneys is that you are seeing an increase in bicarb resorption. Bicarb is again resorbed in the proximal convoluted tubule. Why are we saying this? So essentially what's happening with hypovolemia or contraction alkalosis, you're losing salts, and your body doesn't like that. So the idea is you want to regain this like sodium and chloride that you're losing. So when you are reabsorbing bicarb, sodium comes with that. If you don't remember why, go back and look at it. And then in the collecting ducts at the same time, you are also increasing your hydrogen secretion. As well as your potassium secretion. And again, at the same time, the reason why is because both of these increase your sodium resorption. So you want these back in your body. That's why all these things are also happening. Thiazide diuretics kind of goes back into all of this stuff as well. So it goes back here. That's basics for metabolic alkalosis. There's also chloride resistance ones, but we're not really going to focus on those. Boards covers this really well, so I'd rather get to like question solving stuff. So ideally, what happens with chloride resistant is that your urinary chloride is greater than 40. So something is causing the chloride to go out as a result of the alkalosis. Things that cause this are hyperaldosteronism, Cushing's can cause this. If you have a high alkali load, so let's say like you're using a lot of like antacids for your stomach, that can cause it. Diuretics can also cause chloride-resistant alkalosis as well. Something that's interesting is hypokalemia can cause this, which I thought was interesting because it kind of works both ways. So generally, in a cell, you're going to have a transporter for both your hydrogen ions as well as your potassium ions. So let's say you have alkalosis and there is decreased hydrogen ions in your circulating fluid. You need hydrogen ions to come out of your cells. And in response to that, potassium is going to go into the cell. At the same time, it can go both ways. So let's say that there is decreased, for some reason there's hypokalemia, and you need potassium to go out into the circulating fluid. In order for that to happen, hydrogen will go into the cell, and that can cause alkalosis as well. So alkalosis with hypokalemia kind of works both ways, which I thought was really interesting. Okay, let's go on to metabolic acidosis because it's definitely the hardest thing to wrap your head around. So what do we have? Acidosis, you got a low pH. Metabolic means that you have a low bicarb. You compensate by having low CO2 as well. Again, why is that? You look back at your Henderson-Hasselbalch formula. Hasselbalch. I can't say
It's
it.
forever gonna be Hasselbalch now. Elaborate.
Yeah. Henderson-Hasselbalch formula. I will never say it correctly. I'm sorry. Just look at that. If one goes up, the other has to go up in order to compensate. And yeah, fantastic. Okay. Mechanism, there has to be some sort of increased production or ingestion of acid, or there has to be a loss of bicarb. So at this point, this is where it gets interesting. There is something called the anion gap. And we only really look at it when it comes to metabolic acidosis. So the anion gap kind of looks at the fact that there's a bunch of different cations and anions going through like your blood and your fluids, but we don't measure every single one. The ones that we do measure, so the ones that we do measure are going to be your sodium, your chloride, your bicarb, and sometimes we'll also consider your potassium in the anion gap as well. And this is only if it varies a lot. If it doesn't vary that much, we won't consider it. So the idea is that we will add or subtract the concentration of everything that's going on here. And we will come up with a gap. So the difference of all of it will kind of give us a reference range between like 6 and 12 moles per liter. And the idea is that that is calculating, your anion gap is calculating the number of unmeasured anions minus your unmeasured cations. How does that kind of help? So the idea is that if your anion gap is within normal range, that means that you are, so a normal anion gap, that means you're mainly just losing or gaining bicarb. Well, you're losing bicarb because it's acidosis. So that means the main thing is that you're losing bicarb, and that's going to be compensated with chloride. And that will give you a normal anion gap. If you have a high anion gap, that means that you are either, you're probably gaining some sort of organic acid. And we will go into what that means. So organic acids are like your phosphoric acid, your formic acid, your lactate, your keto acids, anything else in that body that is acidic can make up that anion gap that we're just not measuring because we only measure these four. So that's kind of the broad idea of what's going on. So kind of looking back, so we have your normal anion gap acidosis. So main things that can cause that are anything that's causing that decrease or that loss in bicarb. So a GI loss of bicarb could be like diarrhea can cause that. Diarrhea can also, just remember, if you're losing that, you also lose potassium as well. So you'll definitely see, you'll see hypokalemia as well as your acidosis. Saline infusions will affect your anion gap. So what happens is that you see an increase in chloride, and you see something called chloride toxicity. And then this excess chloride will then drive potassium out of the plasma. You already have one anion, you don't need the other, it's going to push it out of the plasma. And when you have low bicarb concentration, your overall concentration of CO2 bicarb is going to cause that acidosis. Something else that causes it, Abby did talk about acetazolamide. You talked about it for hikers or
Blood versus respiratory alkalosis as medication.
Okay, yeah. So the reason why she talked about it is it's a carbonic anhydrase inhibitor. So that's also going to block the formation and resorption of resorption of bicarb. And another one I think would be good to know is spironolactone. This causes a loss of aldosterone effects. So something else that causes that is, you'll learn about this later, but like Addison's disease causes kind of the same thing. And this decreases your ability to excrete hydrogen effectively. So, okay, so again, I just want to say, like, anything that has a normal anion gap, the really only things you're talking about are anything within these four. So if it affects those four, you're going to have a normal anion gap. We're going to talk about the anion gap ones, the high anion gap ones now. So that's going to involve something that's not those four anions or cations. I feel like I just never understood this, and that is just like what really drilled it home for me. So high anion gap acidoses, it's your mud piles. So boards covers this pretty well, but I'll just group them up for you. So you have methanol, uremia, diabetic ketoacidosis, propylene glycol. You have iron or isoniazid.
Yes. Okay.
You have lactic acidosis, ethylene glycol, and you have salicylates. Did you talk about aspirin? No.
Yeah, I didn't talk about it.
Okay, so let me just highlight some of these that kind of just get grouped together. So methanol, ethylene glycol, propylene glycol, thank you. Yeah, let's group these three together. So the reason why we're grouping these together is they are all some sort of like poison. So just think like antifreeze. And when they are metabolized in the body, so they're either going to be like methanol is a CNS poison, ethylene glycol I think is like kidneys, propylene glycol. It's also used for like IV benzos. So if you increase titration of your benzos, you might also get propylene glycol acidosis related to that. But all these are going to be metabolized and they form an acid that is not within this anion gap. So when you don't create something that's within that anion gap, you create a high anion gap. So things that they create is like formic acid. These are things that you just like need to learn. I don't know why. Propylene glycol is like pyruvate, acetic acid, so acetate, and lactic acid. And ethylene glycol makes glycolic acid and oxalate. So again, if it's not bicarb, if it's not chloride, hydrogen, potassium, you're going to see a high anion gap for something. Why do we see uremia over here? So you see uremia if you're having any sort of advanced kidney disease. If you have some sort of advanced kidney disease, you are seeing reduced hydrogen secretion, but you'll also see retention of a bunch of organic acids. So you'll also see retention of like bicarb and all that stuff as well, but other ones that will also happen is like you'll see your phosphates, your uric acid, you'll see your sulfates as well. So all these are being retained. So bicarb might be retained as well. Potassium might not be secreted, but the idea is that you are retaining all these other things that are increasing your anion gap. DKA is an interesting one. So diabetic ketoacidosis happens if you have type 1 diabetes mellitus. What happens is you have an increase in glucose and not enough insulin. And that increase in glucose is going to make you want to pee a lot because with too much glucose needs to go out somehow. Your kidneys are going to excrete a lot of urine. You go through diuresis. So you see polyuria, polydipsia at the same time because you have a shit ton of glucose, but you don't have enough insulin. Something else needs to make your ATP. So you're going to see fatty acid metabolism. And those are going to create the acids that we're talking about that create the anion gap here, which is beta hydroxybutyrate and acetoacetate. I like that because like beta and butyrate go together and aceto and acetate. It's really nice. Perfect. Other things. Iron causes toxicity if you have too many iron tablets. So iron toxicity can like cause, it can cause a GI obstruction, it can cause shock, it can cause hypoperfusion, so you go through lactic acidosis there. Your main anion gap cause is going to be your ferrous ion, so your Fe3 plus, or your ferric ion. Yeah, ferric is, that's Fe3 plus, ferrous is 2. Okay, there you go. Cool, so iron toxicity, you're gonna see ferric ions, that's gonna cause your anion gap. You'll also see lactic acid, but we'll talk about lactic acid in a sec, that makes sense. Isoniazid, yeah, that. It is tuberculosis meds. It can cause an anion gap because it frequently causes seizures. When you have a seizure, you are going through lactic acidosis as well. And I think that's a great transition into lactic acidosis. Lactic acidosis, I think this is pretty obvious. So you have low O2, you're going to go through anaerobic and aerobic metabolism. A byproduct of that is a lot of lactic acid. Lactic acid will go into your anion gap. And last one, salicylates, it will go through oxidative phosphorylation. So this isn't an acute thing, this happens after the respiratory alkalosis, yeah. Phosphorylation. So the increased anion gap is caused by pyruvate, I think lactic acid, and keto acids as well. So I just can't stress this enough. If it's not one of these four that is causing your acidosis, it's probably gonna have a high anion gap. Does that make sense? Sorry, I just like kept talking. Okay, cool. Okay, so we're just gonna go over like very basics, like how are we going to answer these questions?
Yeah, you're definitely gonna get at least one, if not more, on your final exam, so.
Yeah. Okay, so step one is you are going to say, what's the pH? Normal pH, I just think it's easier to say 7.35 to 7.45. Boards likes to say that normal is 7.37 to 7.48, which I think just kind of gives you more like leeway into saying if something's acidotic or alcoholic. But okay, so let's say it's below that 7.37. Pretty obvious it's acidosis. And if it's above that 7.48, we know it's alkalosis. Great, so we did step one, that's beautiful. Step two is you need to say what's the CO2 and what's the bicarb. So what's going on with these? We need to see what is generally normal. So PCO, so your CO2, normally it's going to be between 35 and 45, but I would just say think 40. 40 is your normal. Your bicarb normally is between 22 and 28. I would say think 24 as your normal. Okay, so cool. Those are your normals. We need to see what's high and what's low at this point. And with that, you're going to determine your initial disorder. So what is the initial problem? And what helps me here is thinking about Rome. So respiratory is going to be opposite, and metabolic is going to be equal. So acidosis, you have a low pH. Let's say you have low pH and high CO2. That is respiratory opposite. So you have a respiratory acidosis. Let's say you have a low pH and a low bicarb. That is low, low, metabolic equal, with a metabolic acidosis. Let's go to the alkalosis side. You have a high pH, let's say high pH, low CO2. That is going to be respiratory and alkalosis. High pH, high bicarb, metabolic same. You're going to have metabolic alkalosis, my bad. Cool. One thing that we're going to do here is, let's say we have a metabolic acidosis, you are going to calculate the anion gap. Sometimes you won't have to, like sometimes the question or the situation will be obvious enough. Like you'll know, like, okay, in this situation, there's always like a DKA, like there's always going to be high anion gap.
Yeah.
That's just something you know, and you probably won't have to calculate it. In case you do, here is the formula. You are going to take your cations and you are going to subtract your anions. Fancy formula. If you are going to consider potassium, very unlikely, but that's only if potassium changes a lot. But that's going to change what your normal is. So normal anion gap is between 8 and 12. With potassium, you're going to look at 10 to 16. So don't really worry about that. I would just worry about 8 and 12 for right now. Cool. So we're calculating the anion gap for metabolic acidosis. So let's say it is between 8 and 12. You have a normal one. And if it's above 12, you have a high metabolic acidosis. This is when you're going to be thinking of your med piles. For your normal, Ambrose has one that says fused cars. And yeah, it's a lot though. Okay, fused cars is a fistula. Here, I'll put this over here. Fused cars. So fistula, that's like biliary or pancreatic, a uridogastric conduit, which I don't even know what that means. It's like this is excessive. I don't think you need to know this. Saline administration, that you need to know. Endocrine, that you do need to know. So like Addison's disease, like acetazolamide, that kind of stuff. Diarrhea. Carbonic anhydrase inhibitor, ammonium chloride, which again, chloride causing an anion gap is pretty self-explanatory. Renal tubular acidosis we've kind of talked about. Again, if it changes your bicarb, and spironolactone we have talked about. Fused cars. That goes with normal anion gap. I'll write that out pretty somewhere else. Cool. So we've calculated anion gap. So step 5, what we're going to do is we are going to check for compensation. In general, for your simple disorders, so if there's just one thing going on, your compensation is going to go in the same direction as what went wrong. So simple is same. So let's say you had a high PCO2 for your respiratory acidosis. Your compensation is going to be high bicarb. And again, like when we think back, the reason why is again that beautiful Anderson-Hasselbalch formula. So if one thing changes, the other thing has to change in the same direction in order to get that pH back to normal. And that's just to keep the log the same. If there is low bicarb, you have to decrease your CO2. So it'd be like slowing your breath down, or increasing your rest rate. Increasing rest rate would slow your CO2. If there is low CO2, you're going to decrease your bicarb. And if there is high bicarb, you're going to increase your CO2. I feel like Abby kind of talked about how you do all these compensations, but the idea is increasing or decreasing your CO2 is mainly your respiratory rate. Increasing or decreasing your bicarb, you initially start with your buffers, and then you go to changing your RAS or changing your kidney functions, all that stuff. And then your last step is going to be, was this compensation expected? So this is your time to look for mixed disorders. So if there's more than one thing going on, it might not be super obvious just from the blood charts. And the way to check that is to see, okay, I figured out what the initial problem is. Now I'm seeing that there is compensation. Is this compensation as high as it needs to be? Is it not high enough? Is it too high? If it's above or below what you expect the compensation to be, which we can calculate for every single situation, that means that there is a second disorder going on. And we'll just kind of go over a few of them, but if you are looking at your respiratory ones, there are acute and chronic compensation formulas that I think are absolute bullshit and you'll probably never have to use. So we're not going to go over those. Let's say you have a metabolic alkalosis, your CO2 is increasing, there is an expected CO2 formula. That is helpful. So what you do is you take 0.7 of the bicarb that you have, you add 20 plus or minus 5 to give yourself some leeway because the body's not perfect and it's working to compensate. So this number will give you what you expect your CO2 compensation to be. Same thing, similarly, we're going to look at what happens when you have metabolic acidosis. You need to decrease your CO2. There's something called Winter's formula. Again, so you're trying to calculate what you expect the CO2 to decrease, what level the CO2 is after that. So what you do is you take 1.5 times your bicarb, you add 8, you give yourself some leeway because the body's not perfect, so you say plus or minus 2. So this is kind of how we figure out what's happening. So if this ends up being, let's say this is like, that literally doesn't make sense. Expected CO2, you need to, yeah, well, okay, sure, 15. Let's say 15. Let's say you expect your your CO2 to be 15 and it ends up being greater than expected. So if it's greater than the expected CO2, let's say it's like 20 or something, that means that you have an additional respiratory acidosis on your hands. You have an additional respiratory acidosis on top of your metabolic acidosis. Let's say it's lower than expected. You need to decrease your CO2, but it's gone from what you expected to be 15 and now it's like 12 or something. And 12 is below that plus or minus 2 leeway. So it's less than your expected CO2. That means that you have a secondary respiratory alkalosis on top of that metabolic acidosis that you have going on. And that's really what you got. Treatments, I think boards covers pretty well. I think at this point we should try some questions.
Yeah, and for like the one classic example we talked about earlier, just like salicylate overdose, that classic Winter's formula, you'll see like the respiratory alkalosis and metabolic acidosis. So that's where Winter's formula comes into play, really. So. Okay. Yeah, questions. You good for questions, Nathan?
You want to try some?
Okay.
Beautiful.
You want to stop sharing?
Yeah, sure, absolutely. Perfect, I can charge mine.
Your pencil. I was like, is it gonna come? Is it gonna survive? Will it survive? Okay, so we picked a whole bunch of questions, literally almost all mapped for them. For this week, we have a couple about just the physiology that I went over initially for resp. So we'll start with this one. There's not too many of these.